people we got, Anna?
They're just coming in now. Can you see the number of participants at the bottom?
No, I can. Yeah, 12. Yeah.
Yeah, Rebecca, it looks like it's fairly static, so maybe now's a good time to kick off. Thanks so much.
Thank you. Well, welcome everyone to another episode of our injury prevention sessions. I'm really excited to welcome you all here again. And I know some of you, it's first thing in the morning in the UK, sometime in the middle of the day for people across Asia, and evening here in Sydney and Australia. And I'm here in Sydney, and I'm coming to you from Gadigal land, and I pay my respect to Indigenous peoples across the world on the lands that we're meeting on today. So, as you know, this injury seminar series is a joint seminar series across the George Institute for Global Health and UNSW School of Population Health. We have a group of injury researchers around the world, and we thought it was a wonderful opportunity for us all to get together, showcase the work that people are doing, and give us an opportunity to hear about it. I'm really delighted today to welcome a very dear colleague of mine, Professor Mao-Yi Tian, who I've been working with for many years in fracture care. Mao-Yi is a professor at the School of Public Health and at Harbin Medical University in China. He's also an honorary senior fellow at the George Institute for Global Health and a conjoint senior lecturer in the Faculty of Medicine and Health here at UNSW. He's got an eclectic background. He's done a Bachelor of Electronic Engineering from the UK and an MSc of Biomedical Engineering from the University of Oxford. He has also got a PhD in Biomedical Engineering from UNSW and an MPhil from the University of Sydney in Public Health. So he's very well trained and very, very well credentialed to talk about the topics that he's going to today. His main research focus is using digital health and health technology to strengthen primary healthcare systems for non-communicable diseases and, of course, injury prevention. I'm really delighted that Mao-Yi is going to have the opportunity to present this really significant body of work on hip fracture, which is, as we all know, is a major emerging public health issue in China because of the changing demographics and an ageing population. He and I have to say, I've been very proud to be working with Mao-Yi on a large proportion of this work. A range of research studies on hip fracture in China, looking at the evidence practice gap and looking at guideline-based interventions, understanding barriers and facilitators to uptake, using very strong implementation science frameworks. At the moment, he's now working to establish the National Hip Fracture Registry and develop Chinese hip fracture guidelines. So really, really exciting initiative. So really looking forward to hearing what you've got to say, Mao-Yi, tonight. So welcome, and I'll hand over to you now.
Thank you very much, Rebecca. Actually, I think this is my first time to using my new institutional slides to present, and I really miss the purple, the George purple slide deck. But yeah, thank you very much, Rebecca, and good afternoon, good evening, and good morning, everyone, and wherever you are. My name is Mao-Yi. So basically, today I'm going to share two stories with you. And the first story is my personal story, and then I will tell you a story that includes 7 studies in hip fracture over the past decades in China. Okay, so the lady on the left is my beloved grandmother, and this photo was actually taken about the same time last year when the entire family celebrated her 97th birthday. And 1 month after her birthday, she accidentally fell at home and leading to a fracture on her hip. And she didn't receive the surgery due to a number of reasons. The doctor said she is too old. Well, my father and auntie said there was a lot of risk. Despite I insist, but the voice from the grandson is never strong in the family. So 1 month after she fell, she started to develop pneumonia and pressure ulcers. We celebrated the Chinese New Year with my grandmother, but this is the last one for her. And 1 month after the Chinese New Year, she passed away on the 12th of March. I lost my grandmother 3 months after she broke her hip. I believe there are a lot of people, older people in this country, in China, like my grandmother, who can live much longer and healthier. But they didn't live that longer just because there was a significant gap between the evidence and the practice. And population aging is perhaps one of the greatest success in China over the past few decades, due to the advancements in public health as well as the social and economic development. In the recent national census conducted in 2020, the proportion of people aged 60 and above is almost 19%, while the proportion of people aged 65 and above is about 14%. So what does that really mean? If you really consider the number of population in China, that represents 264 million people aged 60 and above. And that also represents nearly 200 million people aged 65 years and above. This rapid aging raises many health challenges. And the data from the global burden of diseases, the Chinese National Injury Surveillance System, as well as the Chinese National Mortality Surveillance System, has indicated unintentional falls are the leading cause of fatal and non-fatal injuries for older people in China. And majority of the hip fracture actually occur as a result of falls. A recent population-based study using the data from the National Health Insurance System has identified the absolute number of hip fracture increases about 4-fold from 2012 to 2016. They expect the incidence rate remains stable. In addition, the total cost of the hospitalizations showed a very steep rise from $60 million to $380 million over between 2012 to 2016. We therefore conducted a series of interrelated studies over the past decades, mainly to identify the gaps in hip fracture management in China, and further to develop, implement, and evaluate interventions to guide the development of the National Hip Fracture Registry, as well as the National Hip Fracture Clinical Management Guidelines. So the first study we did in a row is a gap identification. And this study aims to describe the population of older hip fracture patients in China and documents the current care for those patients in the national leading orthopedic hospital, Beijing Jishuitan Hospital. Beijing Jishuitan Hospital is the fourth medical college of Peking University and has over 2,000 beds. We then determine if the current care in Jishuitan Hospital were consistent with the UK best practice. So this study was designed as a retrospective audit and reviewed the electronic medical records and extracted data from the EMR, including the demographics, the time from admission to surgery, also geriatrician care, complications, and falls prevention. And this data were then compared with the UK National Hip Fracture Database in 2012 to determine the gaps. So we do have several inclusion and exclusion criteria, and we included those older people with X-ray confirmed hip fracture and admitted to the hospital between December 29 and December 2011. And we excluded several patients, as you can see in the exclusion criteria. So the outcome we selected is actually based on the 6 standards outlined in the UK Hip Fracture Management Guideline, which is called the Blue Book, that includes the admission to orthopedic wards within 4 hours from ED arrival, as well as the surgery within 48 hours from ward arrival, as well as the prevention of pressure ulcers, the assessments of the orthogeriatricians, as well as the osteoporosis and falls prevention assessment as well. So in this study, we found over 70% of the patients were actually less than 80 years old. compared to nearly 30% of the UK patients, and over 90% of the patients from Jishuitan Hospital without aid prior to the fracture, compared to almost half in the UK. And there are actually no patients admitted into the ward within 4 hours from the ED arrival, while in the UK, half of the patients admitted are in the ward within 4 hours. And in Jishuitan Hospital, only 8% of the patients received the surgery within 48 hours from the ward arrival, and compared to over 80% of the patients in the UK. This shows a significant gaps in the other outcomes as well. So in this study, we concluded there was significant gaps exist in hip fracture management in Beijing Jishuitan Hospital compared with the best practice in the UK. And it also highlights the need to implement and evaluate evidence-based interventions for hip fracture management in China. So based on the results we identified in the first very pilot study, we then conducted the second study, which is a pilot intervention. And Jishuitan Hospital developed and implemented a multidisciplinary co-management program in 2015 with the aim to close the gap. We then conducted a study to evaluate the effects of the multidisciplinary co-management care plans on the 6 standards recommended in the Blue Book. So in this study was designed as a retrospective before and after study, and data were collected from the eligible patients who admitted into the hospitals between January 2012 and April 2017. And we extracted data from the electronic medical record system in Beijing Jishuitan Hospital. And the inclusion and exclusion criteria were really similar to the previous study. So the intervention here is a multidisciplinary co-management care intervention. And this intervention was led by orthopedic surgeon as well as the geriatrician, but also involved the other players, including the ED physician, physiotherapists, and others. And this intervention was delivered from May 2015 to May 2017. And we're using the very similar outcomes as we did in the previous study, which including the 6 standards as outlined in the UK Blue Book. And we're using different statistical models for different outcomes and adjusted all potential confounders in the study. So in total, we identified about 3,540 eligible patients, and there are 1,800 patients admitted before the intervention was implemented, and it was about 1,700 patients admitted after the intervention. So after the intervention, there were about 1,200 patients received the co-management program, while the other 500 patients continued the conventional treatment. So basically, this result showing the primary outcome, which has been defined as the proportion of patients received the surgery within 48 hours from the ward arrival. And before the intervention, as you can see from this graph, there are only 6% of patients receiving the surgery within the 48 hours time frame, while after intervention, about half of the patients who received the intervention received the surgery within the 48 hours. And the odds ratio is about 15 and highly significant p-value. So in terms of the secondary outcomes, except the proportion of patients arriving the ward within 4 hours from the ED, as well, and except the outcomes on the force assessments, the other outcome shows a very significant improvement between the intervention and the control. And basically in this study, we concluded this multidisciplinary co-management intervention program effectively increased the proportion of patients receiving the surgery within 48 hours after the admission. But despite that, the factors or the contextual factors associated with the implementation of the intervention remain unknown. And those factors need to be considered or to be addressed before developing a large-scale study. So we then conducted the third study of the entire story, and this study is a process evaluation of the co-management interventions that just been introduced in the second study. And this study aims to understand the contextual factors associated with the implementation of the co-management care models in Beijing Jishutan Hospital, and using a sociological model. It's called normalization theory. And the normalization theory has been validated and widely applied to develop, evaluate, and implement complex health interventions. And in this study, we conducted semi-structured interviews with multiple stakeholders who participate in the co-management program, and identify the facilitators and barriers from the 4 constructs of the normalization process theory. So that including the coherence, cognitive participation, collective action, and reflective monitoring. And we also observed the patient journey and the clinician's daily practice. And we then triangulate the observational study with the observational data with the semi-structured interview data. And we're using a semantic approach to analyze the data. We then map those themes identified onto the normalization process theory framework. So this slide is pretty busy, so I'm not really expect you to read all the information on these slides. But to summarize, in terms of the patient journey at the ED physician provided assessment at the ED, and including the ECG and blood test, and the geriatrician started to provide the pre-operative assessment immediately after patients admitted into the ward. In addition, the geriatrician, physiotherapists, and nurses participate in the post-operative assessment. So in total, we interviewed 10 participants and identified a few themes and sub-themes. So the co-management program was meaningful and valued by the participants. A few barriers to its implementation were identified. So this includes the unmatched investments and benefits, challenges of facing increased workload. For example, there is one quote from the participant saying, "No, there was no other people rather than patients receive the benefits. Never think the program will bring the benefits to us," which means the clinicians. We were just helping run the program. And other barriers, including the limited accommodating capacity of the hospital, and that probably will explain why there is a lower rate of the ward admission within the 4 hours of the ED arrival. And there are also the insufficient training and supervision systems, and also the participants indicate there are difficulties in assessing the information about the effect of the intervention program. So basically, from this study, we concluded there are multiple barriers to the effective implementation of this intervention program were identified, and the key barriers including the less willingness to fully invest in the program, the inappropriate workload allocation, lack of training and supervision, as well as these factors perhaps needs to be addressed before scaling up this intervention in larger hospitals in larger populations. And in the previous study, as I explained, there showed a effectiveness in the co-management intervention program, but whether this intervention is cost effectiveness, it is not known. So we therefore designed a health economic evaluation to investigate the cost effectiveness of this multidisciplinary co-management program for patients with key fracture in Beijing Jishutan Hospital. And this study was led by one of our PhD students, Dr. Peng. So the cost effectiveness of the intervention was evaluated compared to the conventional treatment. And we developed a Markov micro simulation model to stimulate the lifetime cost and the effectiveness. So the cost includes the intervention, the cost of intervention, hospitalizations, medications as well as long-term care costs. And the effectiveness, we're using 1-year mortality averted and QALY as the indicator. Cost and effectiveness were all discounted at 5% per annum, and willingness to pay threshold is defined as 3 times GDP per capita in China. And we also conducted sensitivity analysis. So when we're looking at the result, the incremental cost-effective ratio was about $20,000 US dollars per QALY gained, and the equivalent is about $78,000 per 1-year mortality averted. If we were looking at the willingness to pay threshold, which is about $26,000 US dollars per QALY gained, this intervention program was effective in Chinese context. And also from the probability analysis, we're looking at the probability of 78% of this intervention program to be cost effective. So from this study, we concluded the multidisciplinary co-management program for patients with hip fracture was cost effective, and there is a potential to scale up this intervention program in the Chinese population. So if you just recall the 4 studies which I just presented, they actually were conducted in a single hospital. And most of the stories was around Beijing Tishunan Hospital. But in terms of the generalizability of the intervention program was unknown to the other settings. So we therefore conducted a multi-center study. And this multi-center study was designed as a prospective, non-randomized control study, and to evaluate the effects of these co-management care models of the older hip fracture patients in 6 Chinese hospitals, and the benchmark to the 6 quality standards outlined in the UK Blue Book and compared to the UK. And this study, as I explained, it is a multi-center quasi-experimental study with non-randomized controlled. We included 6 hospitals in the study, including 3 urban hospitals and 3 suburban hospitals. And basically, we applied very similar inclusion-exclusion criteria as the previous studies. And we continuously enroll patients for 1 year from 2018 until 2019. And after the patient enrollment, there are 3 scheduled follow-ups conducted by the platform, including 30 days, 120 days, and 1 year post-admission. So the intervention program was very similar as I presented in the pilot study. It is a co-management care model and spanned from the time of the admission to the ED to discharge from the hospital. At the ED, the patient care was jointly provided by the orthopedic surgeon and the ED physician. And in the orthogeriatric ward, the orthopedic surgeon and geriatrician jointly led the care provided to the patients. And the intervention was only implemented in Beijing Tishunan Hospital throughout the study period, and the other 5 participating hospitals continued the ural care, which is mainly provided by the orthopedic surgeon. So the outcome of this study, still very similar as the other studies. We're using the 6 standards of the UK Blue Book guideline. So the primary outcome, which is the proportion of patients who received the surgery within 48 hours from ward arrival, and the second outcome, including the other 5 quality standards of the Blue Book, and also including the proportion of patients who received surgery within 48 hours from the ED arrival, not a ward arrival, as well as the length of hospital stay, in hospital mortality, as well as 1 year cumulative mortality after hip fracture. So this is a study flowchart. As you will see, we enrolled about 1,000 patients in the intervention group and 960 patients in the control groups. And we follow up all patients for 1 year, and the follow-up rate was pretty high in both groups. So this study is currently, the manuscript is currently under review. So unfortunately, I can't really share the study result with you at this time, but hopefully that I can share the study result with you once our study has been published. But in addition to this study, we also developed some data visualizations as a preparation work to develop the National Hip Fracture Registry. And we set up these data visualizations. Basically, you can see those key indicators be outlined in the UK Blue Book, and you have a visualization seeing how those qualities varies between the different hospitals, as well as the total number of the patients being enrolled in this study program. So based on those collective studies previously, we then decided to develop a Chinese National Hip Fracture Registry with the aim to promote the best practice in hip fracture management. And we hope the National Registry will collect the patients on a routine basis, and also to promote the transparencies of the inter-hospital comparisons, enable the hospital to compare the care and outcomes against the national benchmark and the quality standards, and monitor the program performance over the time, which can also measure the impact of the changes over the time as well, and as well as using the data to support large-scale research in hip fracture. And the development of the National Hip Fracture Registries has been split into 3 stages. Stage 1 is being designed as a Delphi consultation to reach an expert consensus on the core variables which will be included in the National Hip Fracture Registry. And the second stage of the program is to develop the technologies and allowing the data entry from mobile devices, but also allow the automatic data extractions from the electronic medical records through an API interface. And the third phase of the program is to pilot testing the registries in selected hospitals, mostly to evaluate the feasibilities of the data collection, the patient enrollment, and the follow-ups. So the current status of this program is we already set up an initial variable pool, and this initial variable pool was actually from aggregating variables of 13 National Hip Fracture Registry worldwide. And the first round of Delphi consultation already started, and requiring the expert to rate each of the variables from the pool list on 2 domains. One is the importance of the variable, and the second is the feasibility of the variable using a 5-level Likert scales. And this work already been commenced. During the Delphi process, we allow the experts to modify the existing variables as well as to add all new variables if the expert think there is a value to add new ones. And the data analysis of the first round Delphi consultation will be, hopefully, will be completed in early November. And the last work, actually, it is not a study, but I think it's a much more impact of the research we conducted in the past few years. Early this year, we convened a policy roundtable to disseminate the research results to the government officials from the National Health Commission. And 3 months after, the National Health Commission's delegates Beijing Jishuliang hospitals to develop the National Hip Fracture Clinical Management Guidelines. And I think we are pretty excited about that. This is, I think, a recognition of the research we conducted in the previous, but also it also sheds the light of to have a national standards and increasing the uptake of the best practice nationally for hip fracture management. So in this guideline development, we adapted 4 major guidelines. So that including the NICE guideline from the UK, the SIGN guideline from Scotland, NIZ guideline from Australia, New Zealand, and as well as the AAOS guideline from the States. And we're using an adaptive approach to develop a guideline that including 3 phases. Phase 1, setup phase. Phase 2, adaptation. And third phase is the finalization. In the first phase of the setup, we establish a team. We identify the guidelines that we want to adapt. And the second phase is we basically to consider local context for the guideline adaptations. And the last phase is by convening the expert meetings to reach a consensus on the guideline key recommendations. And we also have a customized classification and we from two perspectives. The first perspective, we're using A, B, C, and D. A means we fully adapted from the existing guidelines from the developed countries. B means we partially adapted with local consideration. C means we added new recommendations based on the local context. And D basically means we reject the recommendations from the current full guidelines. And it is not applicable in the Chinese context. As well as in terms of the levels of the evidence, we have green, amber, and red to indicate the level of the evidence. Green means there's a high level evidence from meta-analysis from randomized controlled trials, and amber means that the moderate level evidence, and red is basically that means that's expert opinions. So all the development work of the national guidelines already completed this week, and we already convened 2 expert consultation meetings in the past few months to reach a consensus on the key recommendations provided by the national guidelines. And the first draft will be submitted to the National Health Commission early next week. So just to summarize all the work which I just presented in the past 10 years, we basically including research to identify the gaps, to finding solutions, evaluating solutions, and leading to an impact, which is to develop the National Hip Fracture Registry, as well as the National Hip Fracture Clinical Management Guidelines. But there are also suggest that there are other future works in this space, that including the large-scale trial to provide definitive evidence, using implementation science approach to bridge the gap between the evidence and practice, as well as to promote the integrated care models for older people, and to engage with different stakeholders, including consumers, communities, and governments, to identify a much better solution. So finally, I'd like to acknowledge a lot of people. And without those people, those work can't be achieved in the past few years. So that including Professor Wu, who is the Vice President of the Beijing Jishuitan Hospital, and we thank for his leadership in all the previous work conducted in Beijing, in China, as well as Dr. Minghui Yang, who is a senior surgeon in Beijing Jishuitan Hospital and coordinated all the work which I just presented. In addition, I'd like to acknowledge all the experts from UNSW, the School of Population Health, the Georgia Institute for Global Health, that including a really wide range of experts, as well as the previous and the current PhD students. So finally, I'd like to thank Rebecca and Maggie for providing this opportunity to share the work we conducted in China over the past 10 years, and hopefully that we can jointly to develop more research in this field to address the growing burden, health issues of the older people. Thank you.
Thank you very much, Maui, and hello to everyone wherever you are. I see we have a great group of 32 participants and a wonderful presentation, Maui. I think it was really great to see how this issue has developed over the last 10 years. But I also want to pay my respects to you and condolences on the loss of your grandmother. I'm sure that must have been really difficult for you. But there was one thing that you said in your personal reflection that certainly piqued an interest with me, and that was there appear to be some cultural specificities around whether somebody should have surgery or shouldn't have surgery. That might be an area, and I think you talked about some qualitative work going forward, but might that be an area that you would also look at in the future? We have lots of other questions, but maybe I thought I'd start with that question.
Sure, thank you very much, Maggie. And I really agree. And I think there are some other cultural barriers that we haven't really addressed or identified from the previous studies. And I think in terms of whether there is any cultural barriers in terms of the resistance of receiving the surgery, I think that needs to be addressed in the future work. In particular, if we do have the plan to implement those evidence best practice in the clinical settings, and this needs to be addressed. And those barriers could be arises from the patient level as well as the health system levels. But I agree, those barriers are not well explored at this time.
Yeah, yeah. So there's a great question from a colleague of yours in China, I think from Lei Sai, who asks, is there any qualitative evidence explaining why the Chinese orthopedic surgeons didn't follow the best practice, albeit international studies show that the survival benefits of having timely surgery after hospital admission? I think you did touch on some of that, but maybe if you could elaborate a little for us.
Yeah, so at the moment, one of our PhD students, Jing, is actually writing up 2 papers, mainly is qualitative papers to identify the barriers and facilitators from different stakeholders. So that including from the clinicians, from the patients, from their family members, what are the key barriers to delay the surgery, as well as to delay, as well as not implementing those practices. So hopefully in the next time, I can share with you some details of those findings from those qualitative research. But from the literature, there are well-established evidence showing that having surgery done in 48 hours or quick surgery can increase the mortality of the patients after the hip fracture. So I think there was no doubt this is one of the best practice we have to promote, in particular in low and middle income country settings.
And then a follow-on question then is around follow-up. So you did talk about evidence showing that it benefits patients, but that you were going to follow up at 1 year. What is the 1 year survival, or you don't have that data yet, or you can't share that data yet? I can see you smiling. Okay. All right. Okay.
Yeah. It's being reviewed at the moment. I think that will be we will be having some good news in the next week also. But but I think this study basically re-emphasized the importance of the co-management care for different various outcomes. This is what I can say, really.
Yeah, great. So while people still think for other questions, there's lots of accolades for you, Maui, that you can read in the chat. A brilliant presentation, and I think great to see it laid out that way, because we read your papers in bits and pieces, but nice to see it actually put together and show how it flowed chronologically. But I have a question, and I know Rebecca has a question, but maybe as I have the chair, I shall ask mine first. I know that the other area of work that you work in is around food and food policies, and I'm wondering whether there are any synergies between hip fractures and the work that you're looking at around foods, and whether you could elaborate for us.
Yeah, I think this is an interesting area, and this is something that I'm really keen to explore in terms of, I think there are some dietary risk factors related to osteoporosis, and osteoporosis, leading is a key risk factor of the fracture as well. So I believe there will be some syllogism between, those different relationships. But at the moment, I think we are lack of the evidence, a lack of the data, in particular from the nutrition perspective. And in the previous study, we didn't really collect any information related to dietary risk factors from the patients. I think, in particular ways, the growing development of the information systems, we are currently identifying the linkage between the different systems, and hopefully that we can having different information system be linked and connected, and we'll be having a much range of a wider information that we can explore those associations. But Maggie, I think this is a really interesting area, and I'm very interested to explore in the future research.
Okay, great. Rebecca?
Well, actually, I'm just going to say Jackie's got a comment in the other chat, which is around commenting. May, can you comment on the availability of geriatricians in China and the challenges of delivering a truly shared care model, which I think is a great question. I do have some other comments to make, but I'll wait until afterwards.
Yeah, thank you, Jackie. Yeah, I think at this time, we actually only implemented and evaluated the co-management intervention program in a single hospital. But whether those intervention programs can be applied to the other settings, I think we're still putting a lot of question marks. In particular, in Jishunan Hospital, as I introduced in the very beginning, it is a national leading orthopedic hospital, and all the leaderships in the hospital, they are actually orthopedic surgeons. So they know the importance of this work, and they want to put a lot of resources to make it really happen. But we also ask ourselves, if we replicate this intervention program into another hospital where the hospital president is actually a cardiologist, whether that program can be, seeking the attention from the hospital management to streamline the processes within the hospital. I think this is something that we have to explore from the health system perspectives, and in particular that I think over the past 2 years, Rebecca and other colleagues, including myself, has started to develop a proposal around to conducting a large-scale randomized controlled trial and looking at the effectiveness of a protocol-driven clinical pathways in low-resourcing hospitals in developing countries. And the key component of that intervention program is actually to set up a quality improvement team within the hospital and to coordinate the different stakeholders, including the hospital leaderships, the different departments, the logistics within the hospital to make that really happen. But I think that's going to be a really fascinating proposal if we can receive the funding from the funder. But I think we are still really keen to push that agenda, and we'll be also keen to explore different opportunities to identify the opportunity to conduct a trial of using those ideas, in particular in low resourcing settings.
Mm-hmm. Great. Another great question, and I'm not sure if it is coming from Grace, because I know last time we had a bit of an issue with multiple people being called Grace, but complimenting you again, and also sharing that she also lost her grandparent from a hip fracture. And she mentions that her grandmother who died also had diabetes, and so is bringing up the issue of comorbidities, and whether you've looked at comorbidities in your study.
Yes, we actually did. In particular, in the multi-center study, from the follow-up data collections, we collect data in terms of for patients' mortality as well as their complications from that study. So again, I probably don't really have the chance to share a little bit more data around the complications, comorbidities from that study, but which we are currently under preparations, another manuscripts to report the complications of those patients from that study. In addition, that Rebecca led a multi-country study, which is called Enormous, involving a lot of hospitals over the world, and also again, we recruited 13 hospitals in China and recruited about 10,000 patients. But this is not just hip fracture patients, but also including the other fracture patients. So again, once those data become available, we will be analyzing, looking at the complications, comorbidities in this particular patients group as well.
Okay, great. Thanks, Maui. And as suspected, that was Samina in India who was asking that question, not Grace. Rebecca, over to you for your comments.
Oh, thanks, Margie, and thanks, Maggie. I'm really interested in hearing your thoughts about how we can affect change at large scale, because we're mostly interested in systems level interventions, and we know we don't want to just I think obviously you need change at the hospital level, but you need a systems-wide intervention. And of course, it is more than just ortho-geriatricians and surgeons. We need nurses and physiotherapists and obviously hospital administrators. What do you think? I mean, again, putting aside, wonderful hospitals like our partners at Jishutan, who are really, the leading orthopedic hospital in China and, at the forefront of evidence. Thinking about rural hospitals in China and other countries in the region and in sort of regional settings, how hard do you think it's going to be to actually, and there are some big cultural barriers. And I think, that first question was about that, changing surgeons' minds about mobilisation post-fracture. And that is very much a cultural thing in terms of surgical culture and risk management and patient expectations. And, there's some pretty intractable issues there that it's pretty hard to shift. And, some of those things may well have really big impacts on mortality. How do you feel about actually being able to shift some of those patterns and actually see that kind of systemic change, for some of those kind of hairy and sort of tricky problems that, you see coming?
Yeah, thanks, Rebecca. I think this is a really important question. And I think most of to be really frank, I think all previous studies is actually only focusing on perhaps it's a macro level of the entire health system. We're just looking at intervention within a hospital and evaluate those interventions. But I think we are lack of the angle to have a higher level angle, looking at from the macro level and to looking at the entire health systems and how those entire health system will actually impact the uptake of those best practices. And this is not just only, as you said, it's not just only the doctors, the physicians, but also including the health officials, the key pillars of the entire health system, as well as the consumer, which will be really important. I think we haven't really had the opportunity to looking at from that level yet, but I'm just thinking about taking your question. I'm just, given the opportunities that we are currently developing the National Hip Fracture Registries, as well as developing the National Hip Fracture Guidelines, I think that probably will be open up some more future opportunities to allow us to conduct research in a much higher angle and looking at from the entire health system and all the players in the health system. I think that will help us to address what are the key barriers, the factors actually influencing the uptake of those best practices, and how can we actually intervene those factors that we identified. So I think I'm probably a little bit optimistic, but given the current development of the National Hip Fracture Guidelines, I think we are pretty proxy to the most higher level of the hierarchy of the policies, and I think that perhaps will be opening up more opportunities to allow us conduct more research from a much wider angle.
I think, the benefits of having registries, which is of course why we want registries, is that it allows sort of a more objective view of the key outcome measures and patient outcomes. So you can look at it and go, well, look at this hospital, look at that one. Even if it's de-identified, you start thinking, well, what are we doing in our hospital? What proportion of our patients are mobilised immediately, and so on. I just have got another question though, and again, it's another tricky question, and it is another one of those kind of wicked problems, particularly with an ageing population and people, elderly people having some kind of expectation that ageing, what comes with ageing is disability and pain and immobility. And so we have seen, and I know you've seen some of the research that you've done in China and again in other countries in the region, that when people fall and have a hip fracture, they don't immediately go and seek care. And there's a whole lot of drivers around that, some of which is just expectation that you're old and that's what happens, but also cost and also the worth, the view of the elderly. And again, I know there's a problem with an aging population and fewer young people looking after older people. What do you think are the points at which, again, and this is a community issue, is how do you work with the community to reinforce the need for rapid, because we know that if people get to hospitals quickly, they're going to have better outcomes, because hip fractures are like heart attacks. They're acute, conditions. So you want to get them treated pretty quickly and before all the comorbidities set in and the other side effects or other complications. So what's your view on that? How do you mobilise the population to get to hospital quicker? Again, there must be health insurance. It must be about cost, transparency of costs and things like that.
Yeah, Yeah, I think, again, I think this is a macro level issue, and this is, it is perhaps beyond the health system really, and involve the cooperation with the other sectors as well. So Rebecca, if we just recall the recent policy review published by one of our PhD students, Peng Peng, I think in that policy review, we clearly identified there is policy gaps in addressing the health system building blocks in terms of including the governance, informations, workforce, service delivery models, and the others. And I think, this perhaps can be having impact to a disease problems as there's a lack of policy. I think, it is, we'll be having those influences on, in terms of causing the delays and reducing awareness from the communities and the others. So I think still, again, I think this is, perhaps is another issue, another research question that we can look at in the future, as we're currently looking at the gaps of the policies. But can we actually jointly develop policies with different stakeholders? I think that's perhaps a really interesting thing that we probably can explore in the future research. And this is what I just learned from Kent Buse from the George Institute yesterday. And he is actually very proactive in co-developing the policies. I think this is really novel idea for me, at least as a Chinese national. As you probably know that, in China, we are one party and we don't really have any too much participations in those decision makings. But whether we can take in the healthy aging or the aging population as an example to have the voices from the communities, from those older people, and jointly be part of those decision-making processes in the future.
Yeah. Wonderful, wonderful, wise words. And yes, the whole public perception and the whole patient perception is really critical. My own mother, at the age of 88, fell, and I could not convince her to have surgery. As far as she was concerned, she was old, she had comorbidities, and she had to die from something. Was her response, and so that whole perception amongst the older population around the fact that surgery is effective and can give you a good quality life moving forward. So I think that there's lots of work to be done at that end of the scale as well. And yes, Kent has done some really amazing work. So Maui, thank you very much for taking us on this fall journey this fall, for those of us that are in the Northern Hemisphere. If you wouldn't mind popping your email into the chat, so if anybody has any further questions or comments they want to make directly to you, they can contact you.
Yeah,
and I
sure.
think
I'm just doing it now.
You'll do that for us. That's great. And then just to remind you that the next session we will have will be on Thursday, the 25th. It's Thanksgiving in the US, I think, but I don't think there are ever too many people from the US joining us because it's too early for them. But the next session will be on the 25th of November. We'll have Nan Tran telling us a little bit about the new Decade of Action Plan for Road Safety, which, if you haven't already registered to listen to the launch, I've just put that in the chat. The launch, WHO are launching that in 3 hours at our, it's 10 o'clock, at our 1 p.m. So if you want to listen to the launch of the second decade of road safety, that's where you need to register. So Nan will be telling us a little bit about the plan, and then we will have 3 colleagues who are working with the Global Road Safety Partnership on the Botner Child Road Safety Challenge, tell us how their projects are speaking to some of the new aspects like gender equality, safer mobility, etc., that the new plan addresses. So if you're interested, those details will be coming to you soon. This recording will be completed, and Anna will send us that in the coming days. We'll send you a link to the recording. So if you haven't been able to listen to the whole session, you can listen to it, or you can share it with friends. We always share it with our colleagues in America because, yeah, they're asleep while we have these. Any last words from you, Rebecca, before we close for the day?
Look, I'd just like to say a big thanks to Mao-Yi. It's been a real privilege for me to have come along the journey over many years working with you on this work. But, you know, it's really outstanding work from the Chinese team led by, you know, it's great. It really is high quality work, and it is going to transform care of hip fracture, you know, in certainly in China and in the region and globally as well. I think it is really important. So just a congratulations and well done. And thank you to all of our joint PhD students. I can see one of them, Peng, is there in the chat. Elizabeth Armstrong, Jing, and Pang Pang. So we've had a number, and I think there's actually probably more that that, you know, have contributed to this work as well. So thank you to everyone.
Thanks, Rebecca. And I see there's one last question, which I'm not going to pose, but Maui, maybe something that you can think about moving forward, and that is the relationship between dementia, the elderly population, and falling. So I'm sure that comes from Jonathan Passmore. I think it's Jonathan Passmore. Yeah, John Passmore. So if you want to think about that, and that's maybe something that we can talk about in the future moving forward. So thank you very much, Maui. Thank you for sharing and for staying up late to present. Thank you, Rebecca. And thank you, Anna, for helping set this up. And we hope to see you at our next session on the 25th of November. Thanks, everyone.
Thank you. Bye-bye.
Bye.